Clinical Student Networks team, postgraduate and undergraduate students and colleagues. A very warm good evening to all. On behalf of our chairman, directors, and the entire SH team, we welcome you all for a monthly virtual CPC meeting. We shall now start our virtual CPC meeting with the interesting quiz questions. So first we have a chest x-ray of a 63-year-old male who came to us for his routine health checkup. On examination, his BP was 120/80, pulse rate was 98 per minute, saturation was 96% at room air. Systemic examination showed S1 was heard in the right fourth intercostal space, S2 was heard in the right fifth intercostal space. Other systems were normal. An ECG was taken for him. The first ECG, what does it show? What are the findings in that ECG? What are the different types of this condition you can think of? With this, what will be your clinical diagnosis? How will you further evaluate him? Following which, we took a second right-sided ECG, which is also shown here. What are the findings in that ECG? What are the syndromes associated with this condition? With this, what will be your final diagnosis and how will you manage him? Next, we have another ECG of a 40-year-old male, known hypertensive, who came to OPD with complaints of giddiness on and off for past 5 days. On examination was conscious oriented, systemic examinations were normal, and ECG was taken for him, which is shown here. What are the findings in this ECG? What do you think could be the cause for this condition? What are the different types of this condition you can think of? What are its complications and how will you proceed to manage him? Next, we had a 60-year-old male who came to the emergency with complaints of breathlessness since 2 days. He was conscious oriented. His pulse rate was 144 per minute, irregularly irregular. An ECG was taken for him, which is shown here. What are the findings in this ECG? You can see. He was also subjected to an echo, which is shown here. What is the classical finding you can see in that echo? What are the reasons for this condition? How will you classify it? How will you manage this patient? And what are the complications you can think of this condition? Next, we had a 42-year-old male, a chronic smoker, present with complaints of dysphonia, deviation of tongue to the right. He gave a history of having aspirated 3 days ago. On examination, vitals were stable. What is your clinical diagnosis? What is the nerve supply to the larynx? Just to know a little basics of it. What are the causes you can think of for this condition? With this, what will be your final diagnosis and how will you treat him? Next, we had a 35-year-old male who presented with complaints of abnormal taste sensation, alleged history of having a head injury following an RTA 1 month ago. What is your clinical diagnosis? From this video, you can see here. What are the causes of element 7th nerve type of palsy? What is the difference between Bell's palsy and Bell's phenomena? And how will you manage him? Next, we had a 75-year-old male who came to emergency with complaints of dry cough breathing difficulty, sleeping disturbance since 1 month. He is a known diabetic and hypertensive on treatment for the past 10 years. On examination, he was conscious, oriented, tachypneic, BP was 170, pulse rate was 112 per minute, saturation was only 81%. On right side, air entry was decreased, right side chest movements were reduced, and X-ray chest was taken for him, which is shown here. What is your diagnosis from this chest X-ray? How will you manage him immediately? A follow-up X-ray was also taken for him, which is shown here. What are the findings in it? What are the causes you can think of for this condition? And with this, what will be your final diagnosis? Next, we had a 54-year-old female who came to our OPD with complaints of palpitation and generalized fatigability since 1 month. This is a clinical picture here. Can you spot the diagnosis? How will you proceed to evaluate her? What are the features of this condition? And how will you manage this patient? Next, we had a 38-year-old female who was admitted with complaints of loose stools for last 20 days. On examination of BP was 110/70, pulse rate was 98 per minute. She was conscious, oriented, and on palpation, abdomen, diffuse tenderness was present. What is your clinical diagnosis? What are the causes for chronic diarrhea you can think of? How will you proceed to evaluate her? After our routine investigations, we had done a colonoscopy for her, and the pictures are shown here. What is the finding in the colonoscopy picture? A biopsy was taken for her. The biopsy specimen is also shown here. What does the histopathology of the biopsy specimen show? With this, what will be your final diagnosis and how will you manage this patient? Next, we had a 72-year-old male who presented with complaints of sudden onset of giddiness, vomiting, right-sided weakness, and slurring of speech for the last 1 day. On examination, was conscious, oriented, BP was 160/100, pulse rate was 88 per minute. He was a known hypertensive on treatment. Seen his examination, though he was conscious oriented, plantar was extensor on the right side, power in the right upper and lower limb was 3/5, left side it was 5/5. DTR was right side was extensor, left side was flexors. With this, what will be your provisional diagnosis? How will you proceed to evaluate this patient? After the routine investigations, we had done imaging for him and MRI was done. The picture is shown here. What is the classical findings you can see in this patient, in these images from this patient? What are the various medullary syndromes you know of? And with this, what will be your final diagnosis and how will you proceed to manage this patient? Here we have another clinical video of a 45-year-old male who came with complaints of abnormal involuntary movements of his fingers and toes as shown in this video. With this, what will be your clinical diagnosis? What is the difference between the two conditions you can see? What is the site of this lesion? What are its clinical signs and how will you treat this patient? Thank you. So as all our delegates are thinking over the answers for the quiz questions, we shall now start our meeting with the prayer as everything starts with the Almighty. Physician's prayer. Dear Lord, Thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I may rely on thee. SAH prayer. Almighty Lord, the source of pink health, we submit our heartfelt gratitude for healing the dreadful and the chronic patients through our hands. Bless our Sundaram Arulrhaj Hospitals with all the doctors and staffs. Let them shine up in their efforts to heal the sick and develop the science of medicine. We thank you, O Lord, for picking us for the health services to create the healthy longevity for healthy citizen and healthy, vibrant India. Thank you. We shall now start our session, our CME. The first session for this evening will be an interesting case of renal failure with unexplained thrombocytopenia, which will be presented by senior consultant nephrologist, Dr. Kanan Baba sir, who is at present the Associate Professor, Department of Nephrology, Government Tirunelveli Medical College, and is also a consultant nephrologist at Sundaram Arulrhaj Hospitals. Over to you, sir. Sir, unmute பண்ணுங்க sir.
Yeah, I'm audible, madam.
Yes, sir, you're audible, sir.
Yeah. Thank you. Good evening, everyone. Good evening, sir. I'm very happy to participate in this scientific program. I'm participating in this scientific program after a very long time, and I thank Arulrhaj sir for giving me the opportunity. And for a short of time, I'm going with the case. You have a 53-year-old female. I have seen this patient in the Tengasi OP. She was presented with a fever for 10 days. And the patient is having the loose stools for 10 days and vomiting as well as anorexia some 10 or 15 days back before all this onset. And she found to have an elevated renal function test and the thrombocytopenia. And the patient was treated by a nephrologist in the Tengasi. And the patient was started with hemodialysis as well as the blood transfusion. And the patient was referred to me for the further evaluation. Next slide, madam. And the patients she doesn't have any comorbidities. Her BP is normal. There is no rash. There is no purpura. There is no petechiae. Next slide. And while evaluating her investigations, her total count is high, and differential count shows polymorphs were low, and hemoglobin is 7.7, and platelets are low. ESR was 70 at 1 hour. So this is the manifestation. The patient initially they presented to my department. Next slide. And we continue with their evaluation. Renal function test, so urine proteins were nil. Our albumin creatinine ratio is 5.3. Her urea is actually this 160. I think I have shared you some other slide. I think her urea is 160 and creatinine is 9.7, and USG shows a normal size kidney. Next slide. Her total bilirubin is 1.1 and OTPT is somewhat elevated and LDH is 1200. And so the problem is she had a 53-year-old lady with no comorbidities, had fever, vomiting, and loose stools, and the thrombocytopenia, renal failure, rise in the LDH, and a total count in CRPs were elevated. There's a mild rise in transaminases. So probably we are treating this patient with the problem started with acute gastroenteritis due to a bacterial infection was suspected. Now she presented with the thrombocytopenic anuric renal failure with the anemia and nephrotic range proteinuria. So the first differential diagnosis, next slide, the first differential diagnosis we offered for her is it can be either thrombotic microangiopathy. The second differential diagnosis, when considering all this condition, we thought that it could be a case of sepsis with acute kidney injury. Next slide. Next slide, please. Next slide. And so we treated this patient as a case of a suspected thrombotic microangiopathy. Either can be a hemolytic syndrome or a TTP. We know that there are two types of TTP. We know that is a D plus, that is a diarrhea plus hemolytic uremic syndrome. Another is an atypical hemolytic uremic syndrome. It's commonly present in patients with pregnancies, post-pregnancy, postpartum cases. Next slide. And usually it is in the biopsy shows there will be a endothelial injury will be there. There will be a fluffy, the fibrin fluffy material will be there in the some endothelial as well as in the glandulus as the interstitial capillaries. There is a particular pathogenesis. Next slide. And we suspect that the patient sometimes the sepsis can present with this following a diarrheal gram-negative bacterial infection. The patient may present with DIC, thrombocytopenia. Sometimes the patient may present with this dialysis recurring renal failure. We suspected these two conditions at this point of time. Next slide, please. Next slide, please. So we continued with the further workup. We proceeded with the peripheral smear. The peripheral smear shows the microcytic hypochromic and with mild anisocytosis and the mild leukocytosis and monocytosis, and the platelets is markedly reduced and normal in morphology. There is no the peripheral smear, no malarial or microphilic parasites was noted. Next slide. And we continued with the investigations. Actually, the serum calcium is 10.9, that's 9.9, 9 to 10.9. So somewhat it is higher. The phosphorus is also higher. The coagulation profile is normal. And so we are dealing with a patient with persistent thrombocytopenia and anemia with an anuric renal failure. Next slide. So, we treated with the patient with hemodialysis. We are giving multiple transfusions, platelet transfusions, blood transfusions, antibiotics, and the diarrhea was settled. The patient is having the persistent fatigability. We are continuing with the other investigations. Seems to be there is a subclinical hypothyroidism is there. Total CPK is normal. ANA negative, ANCA negative. Complements were normal. Next slide. So the issues now is the thrombocytopenia. Her peak thrombocytosis during the admission, we found it is a 72,000. The very minimal thrombocyte, the NAD is 2,000. And there is an anuric persistent anemia. There is a hypercalcemia. It's underway a finding was identified. Peripheral was inconclusive. The serum albumin globulin ratio is normal. Next slide. So we continue with the hemodialysis for her anuria. Sepsis was controlled. So renal biopsy cannot be done because of the persistent thrombocytopenia. So we are in the confusion how to crack this case. So we proceeded. Next slide, please. So we plan to do a peripheral smear. Once again, we are focusing towards the thrombocytopenia. We are approaching that patient. So the repeat peripheral smear shows RBC shows microcytic hypochromic anemia, and so WBC shows there is a large plasmacytoid cells with abundant basophilic cytoplasm. The atypical lymphoplasmacytoid cells present around 10%. The platelets are markedly reduced. There's a biggest clue we identified at this point of time in this peripheral smear. Next slide. So we proceeded with immediately we proceeded with the X-ray skull. So it was a punched out lesion in the skull. Next slide. So we done a bone marrow aspiration. Next slide. The bone marrow aspiration shows the plasmacytoid cells is present around 20% is present in the bone marrow. The next slide. We proceeded with the bone marrow biopsy. Next slide, man. So it shows the hypercellular bone marrow showing the atypical plasmacytoid cells, and a differential diagnosis can be either plasma cell dyscrasia or lymphoplasmacytic lymphoma. Next slide. We proceed with the immunohistochemistry. Next slide, madam. So immunohistochemistry shows the immunoreactive scores. There's a kappa restricted. Kappa cells were dominant in this in the immunohistochemistry. Next slide. We proceeded with the free light chain assay. This kappa is very huge. The free light chain says the lambda is very low. The ratio is more than 800. A very significant rise in the kappa lambda ratio was identified. Next slide. Next slide, ma'am. Some of the slides were, I think I missed. So we proceeded with madam, I will present. Previous slide, madam. Previous slide. Previous slide. I think I'm having some other option, madam. Can I share my slides? Can I share my slides, madam?
Yes, please go ahead.
Please, yes, sir. Yes, sir. Now I think I am now I am sharing my slide. I think is it visible, sir?
Yes, visible.
Yes, sir. Yes, sir. Yes, sir. Sir, sorry, sir. Sorry for that. Initially, I have a huge confusion in the So bone marrow biopsy, immunohistochemistry, and we once again we proceeded with the serum protein electrophoresis. The serum protein electrophoresis, there is no M band. Yeah, there is no M band. So kappa is high. And so the final diagnosis we arrived is a kappa light chain cast nephropathy with an autoimmune thrombocytopenia. It is one of the very rarest manifestation in a patients with light chain, particularly patients with multiple myeloma. So finally, it is what we thought. We started with the diarrhea. If we received the patient with the diarrhea with renal failure, we thought that it could be one of the rarest, very worst complication of this diarrhea is a thrombotic microangiopathy. But found to have with this persistent thrombocytopenia, we repeatedly evaluate, and beautifully the peripheral smear at one point of time, we gave a clue that there is some plasmacytoid cells identified with the pathologist. We gave a very good clue that to proceed further, and we identified all this. We done a X-ray skull, identified the pulsar oscillations, and subsequently we proved all the conditions, and we finally come to the diagnosis. It is a kappa light chain cast nephropathy with an immune thrombocytopenia. So these are all the common manifestations. Manifestations of this common presentations of this multiple myeloma can be either hypercalcemia, may present with renal impairment, and may present with anemia, or may present with the bony lesions, the punctural lesions anywhere else over the punctural lesions, or may present with the osteolytic lesions over the low back region in the lumbar or thoracic spines. So the common presentation, it can be either monoclonal gammopathy of uncertain significance, or plasma cell myeloma, or plasmacytoma, or monoclonal immunoglobulin deposits and diseases, or plasma cell neoplasm. These are all can present as a paraneoplastic syndrome. These are some of the common presentations we are seeing this patient. So this is a case where it is some other case. This is not this patient, and they presented with the cast nephropathy. That's so the fractured cast in the renal biopsy is a very significant. If the patient, I think because of the persistent thrombocytopenia, we couldn't able to demonstrate this cast deposition within the tubules. If we've done the biopsy, I can able to project it. So for the reference, I taken the picture from some other patients and I projected here. So some of the very rare manifestations are that usually commonly all the patients they will present with anemia. So sometimes they may present with hypertensive, particularly when there is a monoclonal immunoglobulin deposition disease, the patient may present with hypertension. May present with hypotension or hypertensive or orthostatic hypertensions may be there. Orthostatic fall in the BP measure, provided the patient may present with amyloid. They may present with congestive cardiac failure, cardiac arrhythmias, or sometimes pinch purpura, periorbital purpura, or pinch purpura. These are some rare manifestations. They may present with gastrointestinal or perforation or elevated alkaline phosphatases, provided the amyloid got heavily in the gastrointestinal tract as well as in the liver. And sometimes they may present with microscopic hematuria. And recently, we are seeing the patient with the inflammation, that is a monoclonal immunoglobulin mediated glomerular nephritis. There's a proliferative glomerular nephritis with a monoclonal immunoglobulin deposition. So nowadays there's a pattern. We are dealing with some of the pattern that's called membranoproliferative pattern. When the adult is nowadays presented with the glomerular nephritis like clinical picture, and the biopsy shows pictures of membranoproliferative like pattern. It is a pattern now. It is the differential diagnosis is wide. One among the differential diagnosis is monoclonal immunoglobulin deposits. We have to rule out all the, we have to do the urine benzones protein, urine this serum light chains, serum protein electrophoresis, and we have to rule out this this proliferative glomerular nephritis in a patient with monoclonal immunoglobulin deposition. And so this is the final slide. So this is a very, very rare presentation. It is a very rare presentation in our very rare presentation. We have seen, we have come across so far as an autoimmune thrombocytic manifestation. Some of the references I have searched in the journals, and from Sanjay Gandhi Institute, they identified this autoimmune thrombocytopenia in a patient with solitary plasmacytoma. Then one reference is there. And some other reference, there is a multiple myeloma. They presented with autoimmune thrombocytopenia. They treated the patient with IV immunoglobulin. First, the diagnosis is difficult. They admitted this case as a case of an idiopathic thrombocytopenic porphyria immune mediated idiopathic thrombocytopenia. They treated as with plasmapheresis. They treated with IV immunoglobulin, and persistently the patient couldn't be able to show any improvement. So automatically they shift the patient. They identified, they diagnosed all these issues, and they pushed the patient towards the CyBOD regimen, the cyclophosphamide, bortezomib, and dexamethasone regimen, and the patient is doing well. So with this, all these references, we pushed the patient towards this. We started the patient towards the CyBOD regimen, the cyclophosphamide, dexamethasone, high dose dexamethasone, and bortezomib, and the patient is showing some improvement. Now her platelet counts is improved, and now her but the persistent the renal damage is there. The patient is continuously, the patient is on the twice weekly hemodialysis through this pump catheterization. But what I am trying to tell is, this is one of the very rarest presentations so far. I am doing this after the post graduation, doing the practice for more than 14 years, and I have come across so many plasma cell disorders. Was referred by the senior physicians as well as my colleagues to me for all the evaluation. But this is the first time I have seen this autoimmune thrombocytopenia in a patient with multiple myeloma. That too a very rare, very weird presentation. We have until the pathologist gave a clue in the peripheral sphere. Definitely, it is very difficult for us to crack all these issues. Thank you, sir.
Thank you, sir, for this excellent clinical case you have shown to us today.
Thank you, madam. Thank you,
The topic is open for discussion. So you can stop
Yes,
sharing your slide.
Yes, ma'am. Yes.
Just close your PPT.
Yeah. Yes, ma'am.
So as of now, we don't have much questions in the chat box.
Hmm.
They can post it even during the other talks, sir. If there are any questions, we'll let you know.
Please. Yes, sir. Yes, sir.
Yes. Thank you so much, sir. If there are no more questions, we thank sir once again, and we shall move on to the next second session, which will be another clinical case, a challenging quadriparesis in the elderly, which will be presented by Dr. Inigo and discussed by Dr. Kannan, consultant neurologist, SH. Over to you, Dr. Inigo.
Good evening to all the doctors gathered here. I'm Dr. Inigo. I'm working as a duty doctor in Sundaram Arulrhaj Hospital. Thank you for giving me this opportunity, and with your kind permission, I will now begin my presentation on the topic of challenging quadriparesis in elderly. So a 73-year-old female patient came to the emergency ward, complaints of bilateral lower limb swelling for past 1 week. She had complaints of numbness of upper limb and weakness of lower limb for the past 1 week. She had generalized tiredness for the last 6 months. The patient had a past history of recurrent fall over the past 6 months, and she sustained a head injury and she was managed conservatively by the general physician. She was a known case of hypertension, GERD, and left renal calculi. She had an history of appendectomy 30 years ago. There are no similar complaints in the family, and she had no history of recent vaccination. And she was on regular treatment for GERD and dyslipidemia. So the key clinical features in this patient are: she's an elderly 73-year-old female, and she had sudden onset weakness of lower limb more than the upper limb, and she had a distal muscle weakness more than the proximal muscle. So the clinical possibilities are slightly Guillain-Barré syndrome, transverse myelitis, compressive myelopathy, inflammatory myopathies, myasthenia gravis, and brainstem encephalitis. So the patient was conscious, oriented, she had pallor, bilateral pedal edema. She was afebrile, BP was 130/90, heart rate and respiratory rate were normal. So the patient has higher mental function and cranial nerve examination were normal. Patient had hypotonia, both upper limb and lower limb. The power in lower limb was 2 out of 5, and in upper limb it was 3 out of 5. The patient was able to flex or extend neck and turning into sides. The patient's sensory functions were normal and other systems were normal. Knee jerk in left lower limb was absent. Ankle jerk and plantar jerk was absent in both limbs. So the provisional diagnosis was made as Guillain-Barré syndrome and demyelinating disorders, and it may be ischemic lesion. compressive myelopathy, and transverse myelitis. So blood investigations were done. The patient had a HB level of 9.9. Electrolytes were normal. Sodium was 145 and potassium was 4.31. The urea level was slightly elevated. It was 47 and creatinine was 1.3. CT brain was done and it shows 10 mm calcification in left frontal white matter, age-related cerebral atrophy with deep white matter ischemic changes. The MRI brain was done and it shows grade 1 small vessel ischemic changes and a old compressed fracture of L1 vertebrae. Ultrasound abdomen was done and it showed non-obstructive large left renal calculi of size 8.9 mm. The echo was done, it was normal. And the patient, lumbar puncture was done in this patient and it shows no cells, sugar was elevated, protein was slightly low, LDH was elevated to 66, ADA was normal, and the culture and sensitivity shows no growth. So it was inconclusive, and then we went for the nerve conduction study, and it shows sensory motor axonal polyradicular neuropathy. So the final diagnosis was made as acute inflammatory demyelinating polyradicular neuropathy and a Guillain-Barré syndrome, old L1 compression fracture, hypertension, left renal calculi, anemia, impaired glucose tolerance, ERB. So the treatment was started. IV methylprednisolone 500 mg was given for 7 days. IV fluids, IV antibiotics was given. The patient was given IV immunoglobulin 20 gram per day for 5 days. The course in the hospital, the patient, 73-year-old female patient came with complaints of weakness in both upper lower limb, more than the upper limb for past 1 week. On examination, patient had bilateral pedal edema and decreased power in lower limb and more than upper limb. And she had a loss of reflexes in ankle and plantar. Relevant imaging technologies like CT brain and MRI was done, but it was normal. CSF analysis was done and it was inconclusive. So the nerve conduction study was done and was suggestive of demyelinating polyneuropathy. The patient was treated with IV antibiotics, IV steroids, and IV immunoglobulin. Physiotherapy was given for this patient. The patient condition was improved and she was discharged. So discussion about the topic of Guillain-Barré syndrome. It is a rare disorder which our body's own immune system attack our nervous system. Weakness and tingling of hands and feet are the initial symptoms. And the exact cause of Guillain-Barré syndrome is unknown, but 2/3 of the patient report symptoms after an infection preceding the quadriparesis. So Guillain-Barré syndrome has several variants like acute inflammatory demyelinating polyradicular neuropathy and Miller-Fisher syndrome, and ophthalmoplegia, ataxia, areflexia are present in the condition, and acute motor axonal neuropathy, acute motor sensory axonal neuropathy. So what causes GBS? Several things can lead to Guillain-Barré syndrome, like diarrhea due to Campylobacter jejuni is one of the most common cause of Guillain-Barré syndrome, and viral infections like flu and other infections with cytomegalovirus, Epstein-Barr virus, Zika virus, and other viruses are known to cause Guillain-Barré syndrome. And very early people have developed Guillain-Barré syndrome in days or weeks after getting vaccinated. So the signs and symptoms are unique to Guillain-Barré syndrome. It is symmetrical both sides. Symptoms appear quickly within days or weeks instead of months, and there will be loss of reflexes, high protein level in the cerebrospinal fluid. So the diagnosis made based on CSF analysis and nerve conduction study. So the treatment, coming to the treatment part, we can do plasmapheresis or give IVIG. These both are the two main immunotherapy treatment for the Guillain-Barré syndrome. Plasmapheresis attempts to reduce the body's attack on nervous system by filtering the antibodies out of the bloodstream. And similarly, administration of IV immunoglobulin neutralizes harmful antibodies and inflammations. These two treatments are equally effective. So take-home message of this case is the patient, an elderly patient and with acute infective condition presenting a quadriparesis should consider acute inflammatory demyelinating polyneuropathy and consider other comorbidities too. And lumbar puncture nerve conduction study are the key to diagnose this condition. And even simple steroids can do wonders in this case. So thank you. I would request Dr. Kannan sir to discuss about this case.
A very good presentation, Inigo.
Thank you, sir.
So clinically how to differentiate GBS from other cause GBS mimics like transverse myelitis or compressive myelopathy in clinical settings?
Thank you, sir. Thank you for the question. In Guillain-Barré syndrome, there will be ascending symmetrical weakness and reduced or absent reflexes, and there will be no sensory involvement. But in transverse myelitis, there will be often sensory involvement, bladder and bowel involvement, and there may be hyperreflexia in the initial stages. In compressive myelopathy, especially in elderly patients' spinal pathology, they may show asymmetrical weakness, and there will be a sensory loss below the lesion and sometimes spasticity. So in our case, there is no sensory involvement, and there is symmetrical motor involvement, hypotonia, and areflexia. And these all key features point towards Guillain-Barré syndrome. And nerve conduction study provided confirmatory support.
So here we are treated with IVIG. So what is the dose and what will be precautions you have to take for giving the IVIG?
Thank you, sir. Thank you for the question. The standard recommended dose for IVIG is 0.4 gram per kg body weight per day, and it will be given for 5 consecutive days. So, for example, if a patient for a patient of 70 kg, the daily dosing will be 0.4 into 70, which will be 28 gram per day. So, 28 gram per day will be given for 5 days consecutively. So, best outcomes will be there when the treatment is initiated within the first 2 weeks of symptom onset, and giving IVIG is equally effective as plasmapheresis. So in an elderly patient with a pre-existing renal dysfunction, IVIG should be given with special precautions. So in such cases, use a lower infusion rate, ensure adequate hydration before and during the therapy, prefer a non-sucrose based IVIG formulations, and close monitoring of renal function should be done daily. So if the renal function is significantly compromised or worsening, then plasmapheresis became a suitable alternative. So it's equally effective in GBS, and it avoids the renal stress associated with IVIG. So in this case, we chose IVIG with close monitoring because the patient renal function was borderline. The urea creatinine level was 1.347. So, but in more severe renal impairment case, plasmapheresis would be the preferred option.
Okay, Inigo. It is very nice presentation. It is a Amson variant of GBS, which is improved. Most of the things are improved, but patient will still have some residual deficit. So Amson variant of GBS will usually have some residual deficit. So that will be improved after 3 to 6 months of physiotherapy. Thank you, one and all, for giving this opportunity.
Thank you once again for giving me this opportunity.
We thank both Dr. Kannan sir and Dr. Inigo for the well presented and discussed case. This topic is also open for discussion. If anybody asks any questions, you can let us know, or you can post it in the chat box also.
I had a very different patient in the last April, I think, yes. A patient, she was referred for, madam, I am audible.
Yes, sir.
Audible.
Patient was referred for, a diabetic patient was referred for proteinuria and bilateral pedal edema and weakness of both limbs. And the patient was on native medicine for 3 to 4 months duration. After all these issues, the patient developed all this, the weakness as well as the pedal edema as well as the proteinuria. So it was some mercury-like preparations the patient was prescribed with. And referred, and I done a renal biopsy, and I have the suspicion that because of the neurological involvement as well as the proteinuria simultaneously following a native medicine abuse, I thought it could be a case of secondary membranous nephropathy due to the mercury toxicity. But the biopsy shows the features of only diabetic nephropathy changes, renal pathological society type 3. So there is a confusion. I called the neurologist, and he done nerve conduction study. Nerve conduction study shows features. So there is a prolonged latency, everything, and it finally it came under the case of Guillain-Barré, acute onset of Guillain-Barré syndrome. It's a very difficult matter, and the patient was treated with the IVIG EG and patient recovered well. So, it's a very different presentation, I think. Everyone thought that the problem could be due to this mercury toxicity, but better the case turned out to be because there is a history of mercury intake is also there. It's a very difficult presentation. I think we can present this case at one in this forum at some other time, I think. Thank you.
Thank you, sir, for your interesting inputs and the interesting
Thank you,
case.
Thank
If
you.
there are no more questions, we shall now move on to the last agenda of today, for which we request our chairman, sir, to give his concluding remarks about both the clinical cases and also to discuss the answers to the clinical album. Over to you, sir.
Both the specialists have excelled in their presentation of cases and in their discussion also. I should really appreciate Dr. Kannan Baba for
Thank you,
sharing
sir.
his time. Hello.
Thank you, sir. Thanks, sir.
For sharing his time and bringing out a very unique problem. Autoimmune thrombocytopenia in multiple myeloma is a very rare combination. We see multiple myeloma, we see thrombocytopenia, we try to make out it's autoimmune, try to put them on steroids and then improve on them. But both combined together, he has made out an extensive evaluation and brought it out. Surely it will be a boon to the postgraduates. Thank you, Dr. Kannan Baba.
Thank you, sir. Thank you, sir.
Second case is also equally interesting. See, there is a paraparesis. Whether it is upper motan or lower motan is the issue. When there is a distal weakness which is more and flaccid and plantar no response, it is usually lower motan. It can be confirmed by a nerve conduction study. When it is done, it is usually a polyneuropathy. Can be inflammatory polyneuropathy or its variants. When there is an upper motan signs and plantar upgoing, we will have to go for a spinal cord lesion. Though there can be a spinal cord lesion in rare cases of inflammable in body, usually that is a myelitis. That is a major differentiating point, which Dr. Kannan has done well and Inigo has also presented well. The second component is how to make a diagnosis. The classical signs are two. One is a cytoalbuminological dissociation. Protein is higher than cells. Here this has not happened. In that situation, nerve conduction study, you will have to go in for it, which Dr. Kannan has done it as proved. And the treatment of choice is either a plasmapheresis. We have done a plasmapheresis earlier and we have shown a lot of improvements when patient is not able to afford for a IV immunoglobulin. Now the affordability of the patients have improved well, and then IV immunoglobulin is a treatment of choice with steroids. This lady has improved well. It tells you make a clinical diagnosis of upper motan or lower motan paraparesis. What is the cause for it? And try to treat it with the IVG, and if plasmapheresis available, fine, or with IV immunoglobulin with the steroids and supportive measures. Thanks to our neurologist, Dr. Kannan. Now coming to the clinical album here, we have first a very interesting problem here. If you see the ECG, all complexes are reverted. Lead 1, P wave, QRS, T wave, everything is inverted. And you see the, AVR, everything is up. Chest leads, everything is decreasing, R wave. Normally R wave, amplitude must go up, it is coming down. You can make a very quick diagnosis, it is a dextrocardia. Whether it is a dextroversion or pseudo-dextrocardia or a technical dextrocardia, you will have to differentiate. The ECG itself will be able to show that only lead 1 and AVR showing and chest leads are normal. It's technical dextrocardia. The technician has placed the reads wrongly. But if you take an X-ray chest, you see this X-ray chest, it is a, dextrocardia with situs inversus. Usually the right lobe has to, right dome has to be above. Here left lobe. Here this is gastric shadow should be here. Here liver shadow should be here. Therefore, total situs inversus has happened. This is usually a benign condition. May have a congenital cardiac disease and these cardiac syndromes, all these things, but it's usually a benign condition. I have seen that when I started my practice, one of the ministers from our area who came to me for some respiratory problem, I suspected his apex beat is not there on the left side. It was there on the right side. Took an ECG. It was a surprise. Then he went to Chennai. All the chaps looked at him. His wife and children rushed to me whether something will happen to him. No, he'll be all right because dextrocardia with situs inversus is invariably 99.9% benign. He'll go to the second case. It's very interesting. I always used to say, when somebody has a CNS problem, of course, you'll have to look for the causes in the brain by clinical examination, ECG, EEG, CT, but never forget to examine the pulse rate, carotids, and heart, because the cause for neurology often lies in cardiology. We should not miss it. This 40-year-old man came with a known hypertension, came with giddiness on and off. Just checked his pulse rate. It was totally irregular. Took an ECG, shows runs of ventricular premature beats. It can go for a ventricular tachycardia at any time. Had some, electrolyte abnormality, calcium abnormality. There can many causes for it, like autonomic neuropathy, cardiomyopathy, coronary artery disease. But usually it is due to an autonomic neuropathy. When we control it with a, antiarrhythmic drug like amiodarone, it goes well. The message here is the cause for neurology, that is a giddiness, can be due in the heart, that is due to a rhythm disturbance. This is one of my earliest cases of, rheumatic mitral stenosis. We see a ball valve thrombus. Nowadays, we don't see this, because those days antiplatelets and anticoagulants were not this much effective. Now we have a very effective one. You see the mitral valve, which is so much thickened and not opening at all. Severe calcific mitral stenosis. You see a big thrombus inside the left atrium. It is very much LR. You see some internal effort, which shows a soft, clot. Soft clot and a half clot. The treatment, only treatment available is, it has to be opened up, has to be removed, mitral valve has to be replaced. It was done about 35 years ago at Chennai by Salomon Victor at Vijaya Hospital. This patient came back and when there is an atrial fibrillation with ball valve thrombus in mitral stenosis, always be cautious. Embolic episodes are very, very, very common. This is a very, very interesting case, and fairly young fellow. Came to us with a hoarseness of voice. If you see here, the right vocal cord is not moving at all, only left vocal cord is moving. That shows there is a palsy there, whether it's a recurrent laryngeal nerve or superior laryngeal nerve. You will have to look for any, vascular lesions or tumors, and we will have to carefully evaluate. Sometimes simple, infection can also give rise to that. You will have to see that this vocal cord starts functioning, or the other vocal cord also may fail in that situation, may need a tracheostomy. A vocal cord palsy is the commonest cause for hoarseness of voice, and cause must be evaluated. That's a message we pass on. This is a young boy who had an accident and a facial deviation. You see here, a facial deviation. That shows this side is working, this side is not working. A facial palsy, lower motor on the left side. This side is the palsy. This side is the palsy. Secondary, it is a lower motor neuron palsy. It's a lower motor neuron palsy. That is why we are able to see the, facial deviation, everything is there. Usually, this is a complication. We used to say it is an immunological or viral, but can be following a trauma, which is ignored for some time, as in this boy. A simple stimulation, physiotherapy with a short course of steroids will always be beneficial to the patient. He also improved well. This is senior citizen with cough and breathlessness. You see the X-ray, very classical, hydropneumothorax. Here is hydro, here is a pneumo. If you see the upper lobe of the lung, there is an opacity. It's a fibrosis plus a hydropneumothorax. The only treatment is put in the chest tube. Chest tube has been put in. Entire thing has been drained out, and we keep it for some time. Start with anti-tuberculosis therapy with or without steroid, depending on the clinical situation. The patient improved well. The message here is somebody having with a cough and breathlessness, clinical examination, we should rule out a hydropneumothorax. What is a clinical sign? Pneumothorax, there will be hyperresonance. In hydrothorax, there will be dullness. When both are combined, there is an entity called succussion splash. You just move the chest, there will be a succussion splash. As water is splashing inside the chest, you'll be able to see that. You take an X-ray chest, confirm it, drain the fluid out, and usually it goes for, very rarely it goes for fistula. Very rarely. You may have to do a thoracoscopy and then close it. Here it is a very, very interesting case. You see here, there is a prominent of the eyeball. The upper, the limbus is seen means that is a proptosis. See the neck, there is a multinodular goiter. Patient is very thin. There is a simple clinical diagnosis, multinodular goiter, the hyperthyroidism, toxic thyrotoxicosis, very important. Do an ultrasound, evaluate the T3, T4 level, and then you will have to immediately do a thyroidectomy. After that, may need a thyroid replacement. Antithyroid therapies and radioactive iodine can be given, but surgery is the order. See, somebody having a young girl, young lady has a loose stool for going for quite some time. See, today, in today's culture of lifestyle, eating on the streets, loose motions are very common. When it goes for a longer time, always you should suspect whether there can be any specific disease. And the way to fix up the diagnosis is you will have to do a colonoscopy. That will give you the answer. You see here, entire descending colon is inflamed. Taken a biopsy, it shows a irritable bowel syndrome. Has to be managed little more carefully and patient improves well. Chronic diarrhea, always consider an irritable bowel syndrome. This is, elderly gentleman who has some giddiness and vomiting and a right-sided weakness. Clinically, we are able to see a right hemiparesis, then there should be a lesion in the left side of the brain. Left side of the brain that is causing an ischemic stroke. That is number one. Number two, you see, we have done an CT and following that an MR. You find multiple thrombotic infarcts in the posterior cerebellum as well as in the midbrain. Therefore, it is very, very, very interesting, very common in a senior citizen. Beyond middle cerebral artery area, a thrombus. They have got a posterior cerebral artery also. There is a thrombus, a lateral medullary syndrome and a middle medullary syndrome. This is very common in senior citizen. Don't be happy with one sign. There is hemiplegia, that is die. This is not linked to hemiplegia. It is a coexistent because of the vascular lesions, multiple infarction in the cerebral cortex, in the midbrain, in the cerebellum. You see that always an MRI with MRA and MRV helps you and have to be put on heparin and antiplatelets for the lifetime. Always check the carotids also. There may be some problem and homocysteine level also. Message here is multiple brain infarcts are common and focus on heparin and antiplatelets. This is a very interesting, this time we see more of neurological cases. You see this well, the movement here on the left side. It is not an athetosis, not a chorea. Combined there. Chorea athetosis. It is very, very, very common in these people with their involuntary movements. And you should know to make a diagnosis. And usually they respond well to amantadine or tetrabenazine or a depleting dopamine chloride. Only here, what is important is you should recognize. Don't think that it is a trauma. It is a trauma. Trauma is a different way, quickly coming and going. Here, the rifting movement is always classical for chorea, chorea athetosis. We should remember that. And when you remember that, you will be able to make a clinical diagnosis. The treatment is also possible. These people must be followed up in the long run. They may go in for some abnormalities in memory and an early Parkinson's symptom. You see here, very classical chorea because it's very classical. This clinical diagnosis is very important for this patient. Usually they respond well to tetrabenazine or sometimes amantadine. They respond well. Yes, I think we have closed the clinical, album here. Very interesting problems. Once again, we thank our nephrologist, Dr. Kannan Baba, and
Thank
his,
you, sir.
our neurologist for the excellent clinical material they have presented to the benefit of the clinicians and postgraduate. Thank you all. We will see you next month. Good night to you all.
Thank you, sir, for your valuable clinical discussion. We thank all our delegates once again, and let's all meet again next month with a few more interesting clinical discussions. Till then, good night to one and all. Thank you, sir. Thank you so much. Nalla irundhuchu Kannan Baba, sir.
Thank you, sir. Thank you, madam.
Rajan sir, unmute பண்ணி சொல்லுங்க. Sir, ஏதோ view சொல்றாங்க. Rajan sir, unmute பண்ணணும். Unmute பண்ணணும்.
So fine. Excellent cases, and the clinical albums are wonderful. Lot of newer insight we gathered today. Thank you.
Thank you, sir. Thank you so
Thank you.
much.
Thank you.